Hello everybody. Over the next 15 minutes we will talk about what is the state of the art in prostate MRI in 2022. Here are my disclosures. So all of you will be familiar with the modern MRI risk-based pathway. And in this pathway you can see that men are selected for an MRI depending on their clinical state, the PSA, the DRE, and other risk assessments. Men are then divided into having low risk or intermediate and high risk, and it's the intermediate and high risk patients who undergo an MRI. And following on from the MRI, depending on the result, men will undergo a biopsy depending on the preference threshold for biopsy. Biopsies are normally undertaken using MRI as a guide, using targeted biopsies with or without a systematic biopsy. Now, if you follow this pathway, there are four major benefits. The two major benefits arise from the MRI's negative predictive value. And these benefits are a reduction in the number of patients undergoing a biopsy, and two, a reduction in the diagnosis of indolent cancers. There are two other advantages, and these relate to the positive predictive value. So more accurate targeted biopsies and grading, but that is dependent somewhat on the biopsy strategy, and a non-inferiority for the detection of clinically significant cancers, although a lot of studies show some superiority, particularly in men who have had a previous negative biopsy. And this is because the higher the rate of suspicion on an imaging test like MRI, the greater is the chance of a clinically significant cancer. But if you look at this graph, you can see that there are still too many false positive lesions in men with positive scans being PIRADS 3, 4, and 5. And we see the same thing happening at the patient level. So if you look at the patient level, men with intermediate and high risk have higher chances of having clinically significant disease, but about 50% of men are false positive. So in other words, we have too many false positive lesions, and two, we have too many false positive men. And this is an issue. Of course, there are other issues that some of you will be aware of: quality assurance and quality control from the imaging all the way up to biopsies. There's a steep learning curve for the interpretation of MRI and a steep learning curve for biopsies. We know that there's a large inter and intra-observer variability amongst radiologists. We know that in about half the cases, the gadolinium that we give is not helpful, which is bad for the environment. And finally, we see burnout occurring amongst radiologists because there are unfunded activities that we have to additionally undertake, including outlining of regions, of lesions, and of biopsy areas. So I'd like to discuss with you three developments that have occurred over the last year that provide some relief to these issues. One, how do we optimize the choice of patients who should go and undergo an MRI? Two, how do we balance benefits and risks? And three, how will active surveillance be useful? Let's first talk about who should undergo an MRI. Now, these are the four traditional groups of patients that we see. Number one are biopsy-naive men with a negative DRE and a PSA that's elevated, usually less than 15, or men who have a persistent suspicion despite a negative systematic biopsy previously. These are the two groups of men who undergo a biopsy. Another group of men who undergo a biopsy are those men who've had a previous negative MRI or a positive MRI and a negative histology, who have progressive PSA kinetics, and of course we see the use of MRI in the active surveillance of patients. The common thing about these men is that they all have a disease prevalence of between 20 and 50%, and this is important to remember. So if we look at the likelihood of benefit according to disease prevalence, you can see I picked 3 studies here. On the left-hand side, you can see this was a Swedish study where the prevalence was 20%, and on the right-hand side, you see a US study where the prevalence was 50%, and in the middle, you can see a Canadian study where the prevalence was 30%. Now, if you look on the left-hand side, what you will notice is that the greatest benefit, which was biopsy avoidance, is greatest for the lowest prevalence of disease. If you look on the right-hand side, where the prevalence is 50%, you can see that the number of men avoiding a biopsy is less than when the prevalence is lower. The second advantage of MRI was fewer diagnoses of indolent cancers. And again, you see the same thing. So on the left-hand side, you can see how many people avoid a biopsy when the prevalence is low. And when you look on the right-hand side where the prevalence is high, you can see the difference in the detection rate between systematic biopsies and MRI biopsies, only 1%. So you can see how benefit scales with the likely prevalence of disease. So here's a man who's very typical and would benefit from an MRI. You can see that he's got this lesion in the left anterior transition zone shown on the diffusion imaging, which enhances with contrast, and this is a very typical man with a PSA less than 10 and a normal DRE who would benefit. Now, recently we've seen a new group of men being introduced to this list, and that is men undergoing primary screening but with a raised PSA. So primary screening with a PSA of more than 3. And this was recently published in the New England Journal of Medicine. If you look at the prevalence of clinically significant disease in this group, you can see it's 20%. So these patients should benefit from an MRI. And if you look on the right-hand side, you can see that the number of biopsy procedures undertaken is less if you undergo an MRI compared to systematic biopsy. There are fewer benign biopsies if you undertake an MRI strategy compared to a systematic biopsy strategy, and there are fewer diagnoses of clinically insignificant cancers. So you can see how this is a newly defined group of men who should undergo an MRI before biopsy. Now let's talk about the way you can optimize the benefits while minimizing the harms from MRI. Now remember that benefits from MRI arise from true results, true positives and true negatives, and harms from false positives and false negatives. Now we know that the major benefit of MRI arises from its true negative value, which we've already discussed. But the major harm of MRI arises from too many false positives, which result in unnecessary biopsy, overdiagnosis, and active surveillance costs. So how do you go about minimizing the number of false positives? What strategies could we employ? Well, there's a number of strategies that we could employ as seen on this list, but what I'd like to do is to concentrate on the second strategy. The second strategy is to combine MRI with risk factors such as age, such as ethnicity, PSA density, prior history, prior histology. And let's just see how we can combine MRI with PSA density first. Many of you will have seen this table in the latest version of the EAU guidelines on page 32. Here they talk about combining MRI risk scores with PSA density to decide who needs a biopsy. What I've done is I've laid this table out in a different way, and you can see that over here. We've got PIRADS 1 and 2, PIRADS 3, and PIRADS 4 and 5 on the right-hand side. Now, traditionally, you would biopsy PIRADS 3, 4, and 5. if you did that, you can see that the number of men avoiding a biopsy in these 5 series that have been reported is 38%. You can see that the number of cancers that would be missed is 6%, which is less than the 10% threshold that's normally accepted. And you can see that the false positive rate was 45%. Now, if you combine MRI with PSA density, these are the men that will be biopsied. And if you biopsied at the 10% threshold, what would you observe? You would observe that there is no difference in the number of men avoiding a biopsy. It's still 38%. Of course, it's different men, but it's still 38%. You can see that the number of cancers missed is exactly the same, 5%, 6%. So then that isn't very different. But look at the number of men having false positives. You see how the false positive rate goes down by about 6%, from 45% to 39%. And this is this strategy to reduce the number of false positive men if you begin to use a combination of MRI with PSA density. Now, could you extend this? Not only PSA density, but let's use other things. Prior histology, the MRI volume, the age. Well, this was looked at recently by a publication from Imperial College in London. And what you will notice is that at the 10% threshold, there is no difference between using this risk calculator and using PIRADS 3, 4, and 5, which is exactly what we said before in terms of the diagnosis of clinically significant cancers. We expected it to be exactly the same, and you can see that here. But what you'll notice is that there are fewer unproductive biopsies, in other words, fewer false positives, which is exactly what we said with PSA density previously. So you can see how this is a sort of separate validation of the use of a multivariate risk calculator to reduce the number of false positive men. So if we go back to this typical man that we saw previously, he has a PIRADS 5 lesion. He's going to get a biopsy. We put his value into a risk calculator, and it says the probability of clinically significant disease is 91%. Does that make a difference in terms of a biopsy decision? The answer is no. Still going to biopsy. Okay. What about this man? Slightly different. So no family history, a slightly elevated PSA for his age, 2.5. PSA density is normal. This is the PIRADS 3 abnormality. Should he undergo a biopsy? Well, if you put this into the risk calculator says there's a 33% chance this guy is going to have a Gleason 3+4 or above. So that's suddenly pushing you towards a biopsy. So you can see how a risk calculator might be pushing you to do something you might not want to do, which is something you need to bear in mind. So what strategies can you use for these indeterminate cases to decide who needs a biopsy? Ask another radiologist. Do another type of scan, such as the verdict scan. You can use PSA density, we already used that. We can use a risk calculator, or you can ask an AI, an artificial intelligence, or you can biopsy them all, of course. Now, let's ask the AI. The AI says there's something here, but it's on the right-hand side, and it points to an area. So next we need to talk about AI and what contribution it could make in the modern era. So let's look at the potential role of AI or deep learning for the detection of higher grade prostate cancer. And let's start off by talking about improving the speed of data acquisition. So here is the same patient. On the top, you can see that this was a standard MRI with the sequence times for the T2 and the diffusion imaging shown, and the time for the dynamic contrast enhancement also shown. But at the bottom, you can see the role and the effectiveness of the AI in reducing imaging time when applied to T2 and diffusion-weighted sequences. You can see that the T2 sequences are reduced by half in terms of imaging time, and you can see that the diffusion imaging time also reduces from 3.5 minutes to 2 minutes. So overall, what you'll notice is that you've almost halved the acquisition time for a multi-parametric examination. In this case, you can see that the AI was not used to speed it up the dynamic contrast enhancement. Next, let's talk about the role of AI in image interpretation, where there seems to be the greatest excitement. Now, most AIs are built around an architecture that looks something like this. Essentially, there are 5 functions. One is detecting the gland, outlining the gland, outlining the zones in the gland. That's one. Number 2 is detecting a lesion and localizing the lesion. Number 3 is to classify the lesions that have been detected, LOS, level of suspicion. Number 4 is reducing the number of false alarms. So in other words, saying biopsy this area, but don't biopsy these areas. And number 5 is a mapping and contouring function. So these are essentially 5 tasks that an AI would perform. So the most important goal or task for a prostate MRI AI is to focus on non-detection of patients who are unlikely to have clinically significant disease, because that's where the main benefit comes from, remember. So here we need to focus on a patient-level statistic, high patient-level sensitivity and negative predictive value to deliver the 2 main benefits of prostate MRI. The second role is to reduce the number of false alarms in non-excluded men. So here we are trying to reduce the number of lesions that are unlikely to represent clinically significant disease. But we do need to account for the tolerance to false positives. What do I mean by that? Well, let's take a look at this man. So here's a 65-year-old man with a family history. And here you can see that the PSA goes up over about a year. His PSA density is high. Now, when you look at this with an AI, the AI says there's nothing here. The level of suspicion is shown at the bottom. It's 32 on a scale of 0 to 100. So it says this isn't clinically significant, this abnormality. Now, when a radiologist looks at this, he'll say, well, it could be Pyreth 3, Pyreth 4, Pyreth 5. You know, there's going to be some variability in the interpretation of what this is, because it's hyper intense on the high B value, but the ADC isn't that low. In terms of a biopsy decision, I think most clinicians would say, well, I'm going to biopsy this because other factors such as family history and the PSA density are quite high. So you're going to biopsy. You might want to do a systematic biopsy or targeted biopsy or a combination of the 2. Now, you'll notice that the false positive reduction engine is on because we're trying to suppress the number of false positives. What happens if we decide not to suppress the number of false positives? Because this man is in fact tolerant to the presence of false positives because he wants his cancer diagnosed. If we do that, we will see this. Interesting. Now you see how with the false positive reduction engine switched off, you can see how the AI says, well, there could be something over here. Not only does it show you where the lesion is most likely to be, but it's also showing you this penumbra around where it's found the lesion. So what it's saying is not only biopsy that area, but remember to look all around that area, including the right side of the prostate gland. Now, a lot of us would want to see that on the dynamic contrast enhancement. And when you do the dynamic contrast enhancement, you can see how the penumbra exactly matches the abnormality that you see on the dynamic contrast enhancement. So in fact, it is pushing you now towards doing a biopsy, which is of course clinically indicated anyway. Now, if you put this patient's value into the risk calculator, you can see there's a more than 80% chance of this being a clinically significant cancer, regardless of whether you think this is PIRADS 3, PIRADS 4, or a PIRADS 5. So let's just talk about the last task. So the last task is to do with biopsy management. So here, the emphasis is on outlining the gland, outlining the zone, outlining the lesion, and outlining the biopsy area, the penumbra, which I showed you on the previous scan. And that's where we are with Prostate AI today. How about its performance? Well, at the moment, the performance of an AI is as good as a general radiologist. So here is the ROC curve at the patient level. And what you'll notice is that the receiver operating characteristic curve is as good as the MRI first radiologists. The MRI first radiologists, remember, were radiologists at 16 centers in France, where they used a Likert score and using multiparametric MRI. This data is from a biparametric MRI. And you can see how the AI is performing as well as a general radiologist. But look at the false positive rate. The false positive rate at the patient level is 50%, which is what we said at the beginning. Remember, we said about half of the men undergoing a biopsy did not have clinically significant cancers. So the AI is at 90% sensitivity is actually giving you a 50% false positive rate. Now, we want the AI to perform at an expert level, and the expert level is given by those crosses. Now, those radiologists were center radiologists, highly expert. Look at their false positive rate. Their false positive rate is 30%. So what we can say is that the AI currently matches the general radiologist, but is below the level of an expert radiologist. An expert radiologist at 90% sensitivity should have a false positive rate of 30%, 0.3 in this graph. And that's an important thing to bear in mind when you think about purchasing your own AI software. 5 essential points from this lecture. Men with a likelihood of a significant cancer of between 20 and 50% are most likely to benefit from the use of an MRI. Number one. Currently, we are focusing on improving the positive predictive value, reducing the variability and the false alarm rate. And AI is helping us there, but there are other strategies that could be deployed. Remember that you have to tailor your biopsy strategies according to the tolerance to false positive results, whether the patient is biopsy averse or whether the patient is cancer averse. At the moment, AI is performing at the level of general radiologists with the same level of false alarms and false reassurances. And I've shown you both examples. So currently, a multidisciplinary method of prostate diagnosis is still the gold standard for prostate cancer diagnosis. I hope you found this talk valuable. If you want to listen to these topics in more detail, feel free to look at my YouTube channel and these 4 presentations on the right-hand side. Thank you very much for listening.